today. This is such a great event because we're talking about issues that are so relevant here in the city of Calgary. And, it was back in May of 2014 that myself and the Executive Director of the Calgary Drop-In Centre, Debbie Newman, went on a trip to Ottawa to see Dr. Jeffrey Turnbull. And, when we came back, from that sort of transformational experience, the question that we started to ask ourselves, and I know many of the other great shelters in Calgary, like the Alpha House and the Seed and the YWCA for Women and others, the question was, how can we do better, for the 600 to 900 chronically homeless Calgarians? And these folks are, as we know, the point in time count told us that we have about 3,500 Calgary homeless folks, but of that number, probably 600 to 900 of these have been homeless for over a year. I mean, we have over 500 of them in our building alone at the drop-in center. And as you know, with this particular population, they have significant mental health and addiction issues, and the physical challenges that they have far exceed what you or I would have. And at least in the drop-in center, over 60% of these folks are over the age of 46. And so as we can tell, their outcomes won't necessarily get any better without some help. So, several of us agencies began to put together a task force, and we're so grateful that some pretty high-level people in Alberta Health Services, along with Human Services, the Calgary Homeless Foundation, Calgary Police Service, Source, the Mustard Seed, the Alex Cups. I mean, I could go on and on. We've been meeting together thinking about how we could address this challenge more meaningfully. And, we had booked Dr. Turnbull to come actually and consult with us tomorrow, which he's going to be doing at 8 a.m. And so when we had that knowledge in hand, actually I approached Dr. Van Nguyen from CUPS, probably 6 or 9 months ago, and we started talking about, well, we've got this amazing guy coming to Calgary. How could we leverage him, not just for the task force, but also for the community? And, one of the things that is so impressive to me when you think about a guy like Dr. Jeff Turnbull, and I don't really know him very well, but had a couple of privileged opportunities, is, I watched him work with homeless populations in shelter and in supportive housing in Ottawa. And I was blown away by the compassion, by the humility, by the ability to connect. And when you think about a man who, you read off his biography, it's like, there should be a Hall of Fame, right, with his picture there. You think about receiving the Order of Canada, you think about the president of the Canadian Medical Association, and of course the chief of staff at the Ottawa Hospital. And all of these are very impressive, but as a non-medical person, they mean nothing to me if when you engage one of our clients, you don't do so in a way that's compassionate and humble and genuinely caring. And so, I'm so honored to be able to introduce you, Dr. Turnbull, and I wonder if you could all just give him a wonderful round of applause.
Thank you very, very much, Abe. That's very, very kind of you. Not true, but very kind of you. And I see some friends around who actually know the truth about me, so whatever you do, don't talk to those guys. But what I wanted to really say at the beginning, and just as a prelude, as I look around this audience, and when I think of some of the lessons I've learned over the years, and when I've heard the two earlier speakers, which I thought were fantastic. One, I'll never dress that well, and I was exhausted after both of them, and I thought, my God, how will we ever live up to this level of achievement? One of the things I remember when I was president of the CMA and I was raging on about politicians not demonstrating leadership, I was taken aside by a minister of health who said, you don't get it, do you? And I said, yeah, what is it that I don't get? And he said, well, that's just not how it works. How it works is you develop guiding coalitions. You get the grassroots. You get everybody on side. You create a politically safe zone, and we will follow. And when we do something, then you'll support what we do. But we will not lead. And so what I learned from that was everybody in this room is empowered to make this change. This is the group of people in this atrium who will actually affect the well-being of those people most vulnerable around us. It's not politicians. Don't wait for that to happen. Make it happen on your own because you have the power and it will happen. Secondly, this is not about, we had two brilliant physicians and one less so. This is about teams. And I see police, I see paramedics, I see social workers and providers within the shelters and the other shelter staffs. This is about a functional team pulling together to make a difference. And everybody has an equal role in this, and everyone has that equal responsibility that Ryan spoke of. It's our job. We must do this. So that's why I'm going to come back to that right at the end, but I thought it was a worthwhile thing right at the beginning to highlight that. So what I wanted to do is, one, say, unfortunately, I don't have any financial disclosures, but I wanted to begin at a very high level and just talk about health equity. Now, we've gone earlier today, we've talked about high-level social determinants of health, and we've talked about innovative programs in providing services for those homeless people who, in the end of their lives. But I wanted to get into the middle ground there and talk about the issue of health equity. And this is something that is a part of my life. I'm the Chief of Clinical Quality for Health Quality Ontario. The quality movement started around patient safety. They've moved into efficiency and effectiveness, and they're thinking about patient experience, all of those things. But always on every one of those lists is health equity. And also on every one of those lists, the one thing they don't do is health equity. So I thought I'd put this in context and talk about equity and the challenge that faces us as all people who work within these environments, not healthcare providers, because it impacts the judicial system, it impacts our health system, it impacts our financial system. So it's as much a Treasury Board problem as it is a health services delivery model problem. So I'm going to begin first with that, and then I'm going to move from there to talk about inner city health in Ottawa as one strategy, one that you probably will not accept, and I wouldn't want you to, but as an idea to build and fit within your own circumstances. So what are some of the definitions, what we're talking about health equity? And this is the one I like that we're using now at Health Quality Ontario. Health equity is achieved when all Ontarians are able to reach their full health potential and receive high quality care that's fair and appropriate to them and their needs, regardless of who they are, what they have, and where they live. If we could achieve that, then I think truly we would be proud of the systems around us that would serve all of us in our community. There's confusion about what is health inequality and what is health equity. So health inequality is different. So health inequality is when there are differences in health experience or outcomes between different populations. A population who smokes and a population who doesn't smoke. Those people who smoke are going to have a higher incidence of lung cancer. That's an inequality. It's an understood, accountable thing that you have one variable causes another. That's an inequality. But we're talking about inequity here, and that's below. Health inequity, when you attribute these differences to systematic disadvantages that are potentially remediable and considered to be unfair or unequal. The highest incidence of lung cancer on the planet, our Inuit population in Canada. That is unfair, that is unequal. And so that is an inequality that we need and we have the responsibility to address. So what are some of these things? How do we look at inequity? And then I'm going to get down to inner city, because inner city is a strategy, just one strategy to address these. So for those of you probably have trouble seeing that, you know, I'll try and read it out for you as best I'm having trouble too with fairly oblique vision, but inequity in access, the right care, right place, right time. And all of you, I think, would recognize that if you're in a rural and remote setting, or if you're in a homeless shelter in an urban setting, you don't have the same equity as if you were wealthy, access to services, if you're wealthy in a downtown Toronto or Calgary. Care that has to be available, accessible, and acceptable. So Ottawa's got the highest concentration of psychiatrists per capita in the country. We probably need it. However, do you think that I could get a psychiatrist to come down and visit on a regular basis in the shelter when 20% of my people have schizophrenia? I have about, when I look at it, major affective disorder, about 80%. Probably the highest incidence of mental health and addiction anywhere in the city. So we have a challenge that getting even that care, even though it's available, it's not coming to my homeless guys. And if we do provide it, it's got to be acceptable to those individuals. And it's got to be accessible. So one of the things, for example, my colleagues say, oh, you've got to come up to the hospital, come at 9 in the morning, I'll see you in clinic. Well, that is never going to happen. Not for one of my addicted individuals who, at that point in time, are trying to deal with their mental health challenges and their addiction. Don't even waste your time. And when they don't show up, they say, didn't show up, don't ever come back and see me again. And I'd like to think that that was a rare phenomenon, but it happens to me just pretty well daily. And I'm the chief of staff of that hospital. So it's a challenge. Do you think one of my guys, now here I say guys means guys and girls, homeless folks, will ever get on a list to get a total knee joint replacement? Nope, ain't gonna happen. Not today, not tomorrow, hopefully sometime, but that access that we might complain about, getting reasonable access to services, just is not available to this population. And I'm going to show you in a moment how that plays out in the impact that they have on our healthcare system, plus our judicial and also our financial systems. So do they have the same patient experience? Do they have the same outcomes? If you have a stroke in a shelter versus a stroke if you're wealthy? If you have a stroke in a shelter, you're going to have a terrible outcome. And what I would love, what the legacy that I would like to leave for my children would be that equity in health, so no matter what child born at any time in Canada, no matter where they live, what postal code they are, what they have, will have the same opportunity for health. Wouldn't that be wonderful? We are so far from that now. We've got a long way to go. So let's try and work on the first bit, access. So what does that do? And we've heard about that, and I'm not going to talk about it very much more, but just to say that the consequences of inequity are so profound in Canada that I work in Bangladesh, I work in Africa. The incidence of HIV in my injection drug users is higher in the shelters than it is in sub-Saharan Africa, the epicenter of HIV. Hepatitis C is 80% in my injection drug users. Incidence of tuberculosis on a Canadian reserve, higher than where I work in rural Bangladesh. Probably the highest incidence of tuberculosis around people would refer to as Bangladesh, but we have higher rates. I told you about smoking and lung cancer, highest in the planet. If you go from the richest part of Hamilton to the poorest part of Hamilton, life expectancy drops from that 81.5 years by 21 years. Just think how happy we would be if we had an intervention that actually got the population, or even a section of the population, to live by 3, 5, 10 months, not years. We were delighted when our life expectancy went from 81.1 to 81.5 in Ontario. That was a major accomplishment. Well, 21-year difference just by driving down to the poorest part of Hamilton. We know from the Toronto experience, in my shelters, that you're not going to get to the likelihood you'll get to the age of 75 is only 25%. So huge, dramatic differences. So all of us who are responsible and play a role in the shelter environment oversee circumstances that are worse than the developing world. Yet because we publish averages, average life expectancy, 81.5, pretty good. We absolutely neglect massive differences in health outcomes comparable to that of the developing world, as we heard from Naheed. And that's bad. I would argue that that would be really difficult. However, the additional impact about that is it costs us so much money. This is bankrupting the healthcare system. Over 50% of all healthcare utilization comes from the poorest 10% of our population. Our ambulances, our police services see these people on a regular daily basis. They're the same people. They're picking up the same people coming to the emergency department. One of my guys came into the emergency department 191 times in the 6 months before coming into the program. Think about it. 6 months, 191 times. That's a full-time job. You got to think about how you're going to do that. And so that costs a whole bunch. The Toronto folks, Stephen Wang looked at the cost of a chronically homeless person, and you've got, Abe, how many do you have? 400? 400 or 500? The average cost, I think, was $170,000 to $220,000 per person per year. And if they were getting stellar treatment and best care, and that was resolving their circumstances, I guess I might not mind so much. But they get ineffective care and is bankrupting the system. So you could be a hard-hearted economist and really not care about compassionate care for vulnerable populations. You cannot ignore the fact that this is costing way too much money to the healthcare system. It's dominating our police services. Our paramedics are spending most of their time caring for these populations. And I have to say, it's kind of ineffective. So before I move to inner city, the other thing you have to know is, at least this problem's not getting worse. Well, the reality is the problem is getting worse. Social inequity in Canada is growing. And with social inequity growing, health inequity is going to follow. And it's estimated that this is probably bigger than the aging population, the challenge that we face in our healthcare system. Is anybody talking about a gray tsunami for the poor? It's just not happening. But it's estimated that the cost of the healthcare system, and he just put up some costs there, the estimated cost of the healthcare system is expected to be around 20% of all healthcare expenditures because of growing social inequity. Over the last decade, the rich, at a time of restraint and recession, the rich's total income have gone up 40%. The lowest and the most vulnerable of our communities in the lowest socioeconomic bracket, their income has gone down by 150%. So, increasing gap, progressively getting worse, our Gini index is deteriorating, and with that will become increasing health inequity. And that's where we find ourselves. So these are the different principles of health quality, and the one that we've neglected the most is the last, inequity. And if we're going to define how we provide services in this context, we're going to have to provide different models of care, and you've heard about that today. We have to start thinking about our roles and our responsibility to advocate for that population. That's what Ryan does so effectively. And we have to think about different models of care, which Naheed has shown us how we could do end-of-life care in a different context, out of a Honda. Sounds pretty good, actually. Nevertheless, we're going to have to define the nature and the extent of the community involved. If we're going to treat vulnerable populations, we better understand them. Here's the social contract with the university. Where could the university play a role? the university could help us define who those populations are, where they are, what are their unique needs. And then we have to consider barriers to them. So we have to actually ask them, what are the challenges that they face in getting health services delivery? Not ask us, ask them. We're not telling them. All of you know that. You've worked in the shelters for long enough. I didn't know that. I thought I was going to go down to the shelters, give out some antibiotics, treat some TB, and that'll be cool, that'll be great, and then I'd be done. And the model that I thought was going to happen is totally different when they started to tell us how it should be. We listened, and that was the one good thing we did. And I'll explain that in a minute. So we have to think of how do we engage those communities, how do we have to provide care on their terms, not on our terms, hence care out of a Honda. We're going to make this a slogan for you. Pretty soon we're going to brand this Honda Care, something like that. And then we have to think about what are those factors that we have to mitigate in addition as we provide the care to allow them to move away from the circumstance where we're providing care and they're a vulnerable population to a population that gets the usual entitlements that they deserve as any other Canadian. And then, of course, we better define that and measure it and publish to it. Because if you don't have data, the one thing I've learned is it doesn't matter. So, in that context then, let me tell you about what we've done in Ottawa as a collective. And this is by no means me. I was just sort of being dragged along. Ottawa is not that different than Calgary when I talk about it, but we have, where it is, these are the numbers over a course of a year. You can see the breakdown. It used to be 15, 20 years ago when I started in the shelters, it was the domain of the adult male alcoholic. Now we've got children, families, elderly individuals. We have to provide palliative care. We have refugees. We have a different cohort of individuals totally. And combined with that, we have differences in their circumstances. Housing is different in Ottawa now. Social services are different. They've been cut back, and just like all of the things that you experience on a regular basis. And the biggest thing that challenges me every day is I'm trying to react to the next addiction du jour. We went from alcohol, Purell, all the guys would march out to the Parliament buildings first thing 8 in the morning because the Parliament buildings discovered Purell, and the guys discovered it right after that, and so they would clean out all the Purell at the Parliament buildings, and so we were dealing with non-beverage alcohol, and then crack cocaine hit, then street opioids, then crystal meth hit, and now it's all about heroin. And so it's different by the community. Every community has its own unique characteristics, but that's the reality of my world. It's a rapidly changing world and one that I have to adjust to on a regular basis. When I think of what we have to do is we talk to our homeless colleagues and we ask them, what were the challenges you faced? And it's all the things that you think about. Transportation. So I had one of my guys into the hospital just recently, and he had cancer and some renal impairment and some diabetes. And when he left, he was on a whole bunch of different medications, none of which he could get anyways, but so it didn't really matter that they all have interactions with each other, so couldn't get them anyways. At the same time, he left with 4 different appointments for 4 different specialists, all at different times, different places. He had to do this, he had to do that, he had to follow a certain diet, etc. And it was as if this guy looked at this stuff and said, what planet are these guys on? Do they have any idea what my reality is? So no meds, no diet, no home, no follow-up, no transportation. So basically thanks, but no thanks. So these are the other challenges, and I really wanted to talk about the concept of health. Our concept of health is one where you plan for your health, you kind of think that, well, this is, I want to make sure that I'm healthy, I'm going to eat healthy, I'm going to exercise, all those things Ryan told us about. This is not their world. They're dealing in one crisis to the next. The crisis of their addiction, the crisis of their mental health challenge. An appointment at 9 in the morning is useless. They don't have enough money for a cab drive to get up to or even a bus fare to get up to the hospital. They're dealing with their crisis. And when their health crisis gets louder than their mental health or their addiction crisis, then they will come to our care. And somehow, rather than expect them to change, well, this is what we do, we expect them to change to fit into our system. What we have to do is figure out a system that serves them based on the reality of their lives. And I can tell you, health promotion is not something they're interested in. So let me go ahead. We got together probably 20 years ago. We started off really small. We had all of these different health care providers. We've actually now developed a community of people who have rallied around to try and solve the problems of health services delivery for the homeless. We actually probably have another 5 who are, but these are formal members of our board. And so these are the people who run inner city, not me. The service providers, the people in our community run inner city. I'm an employee of theirs. We started off very small. We've grown dramatically. We're about the size of a medium-sized hospital now. We're about, I did rounds this week, we were about 240 inpatient beds. We have, let's see, about 150 personal support workers, about twice that number of volunteers. We have 12 nurses, 4 nurse practitioners, and 1 doctor. And I'm half-time. This is driven by the people who really know how the reality of these individuals' lives. It's a totally different model of care. It's totally team-based. On the members of my team are paramedics, police officers, people who deal with housing, the judicial system. Those are the people I talk to. We don't talk as much about tuberculosis as we do about warrants and diversion and housing. So we've grown. We're now 9 facilities across the city. And the model we've said was, we're going to put our services where the homeless are. We're going to come to them, just like Honda Care. And so what we've done is we have managed alcohol program, which I can tell you about later, and I will in the workshops. We stole that unabashedly from Toronto. We have a diversion program, which I'll tell you about in a moment. And we have special programs. We have a hospice, which Naheed mentioned. We have hotels. We've now got 4 hotels. We find people under fields and under bridges. And it's a coordinated, integrated program of bringing people out of the cold, providing them shelter, and in that context of supportive housing, we provide them services. And it's amazing when you bring them in and then say, let me deal with that foot of yours, and couldn't I help your mental health? And by the way, we can deal with your addiction. But you can't do that if they're crazy in crisis throughout the city, and you can't even find them in a half an hour. You have to have a home for them. May not be a home in our terms, but it has to be a place. So that's what we chose. We chose structural facilities where they could call their home, and we wrap services, integrated service programs around the individual. And you can see all the locations that we are. And I'm just going to talk to you a little bit about one program. So access the right care, the right place, the right time. And these are all the programs. We have a managed alcohol program where we thought we made every mistake going. Trust me. You can never think of all the mistakes that you could make that we haven't made twice. So we had a managed alcohol program, so we were giving alcohol to these guys. That stabilized them. And then they said, we don't want to be here anymore. We want to be in stable housing. We want to be with our family. We want a Christmas party. We want to have a garden. We want a dog. And we want to cook for ourselves. And we said, it's kind of a good thing to do, but we don't have that. So then we suddenly, the back end, we never thought of the back end. What happens when you become into acute managed alcohol program, what's next? We had to scurry around. We had to buy a hotel and put them into that supportive, stable housing. We still found many people coming into the emergency department. Our police, our paramedics were bringing those individuals constantly to us and into the emergency department. We had to do something. So we asked all of them who these people were, and we found out that, in fact, as you might have gathered, there's about 100 guys who are on a regular basis coming in and out of the emergency department. So we said, all right, we'll go find them. We'll tell them to come to us. Don't go to the emergency department. We'll ask our ambulances and police to bring them to us. We'll have a unit where they're stabilized, they sober up, and then the next morning when they're sober, we'll actually say, hey, how about that foot? Can I help you there? Why don't you come back to us? Why don't you come into a managed alcohol program? Or do you want a detox? We'll do that right now. Not in 6 months, right now. How about being part of our community? And how about not going back to the emergency department so that next time you're coming to us? We thought that was better care. Might even save some money. We were funded for 150 diversions. As you can see, true diversions, there are many more people came to us, 618. It was starting to get a bit crazy. Next year, 5,320. This is Mad Max in the Thunderdome. This is 45 beds, drunk and disorderly, everybody in Ottawa. They're coming from the transportation system, they're coming from the Rideau Mall, our police, our ambulance, diverting all of those individuals. Our nurses love it. Best place to work. They just think that this is ideal for them. These are the most dedicated, spectacular people in the world. But you can imagine how challenging this environment is. So those people, and when you look at it, you can provide better care. Nobody got sick. We had to phone the police on 3%. We had to phone the, on 2%, and the ambulance again on 3%. They dropped them off. They deteriorated on their vitals. The police, we said, this person is now sobering up a bit. He's becoming very, very challenging to manage. And so we had to phone the police back on 3%. The rest stayed with us. Nobody got sick. Everybody got better care. We just saved the system $1.7 million. So that was our cost. So can you provide better care? You certainly can. Do you have to wait for permission? No, you don't. Just do it. You are empowered to do this. And you can make an enormous difference to the lives of these individuals and to the healthcare system itself. So I'll end with this just to say, what's our role? And this reflects all of the discussion, and it comes back to my initial comments. We can create information for a healthy social policy decisions. We have a university who you're very fortunate, who is dedicated to this. I think that should be the role of a university, reaching out into their community and provide meaningful research that provides evidence and data to drive social policy. Promote effective health delivery systems for prevention and care. We, as providers in all levels, can do this. We can get involved in advocacy for anti-poverty measures. That's Ryan. We can affect positive social change through healthy social policy. We can create that healthy social policy, and we can promote it. And then we can advocate for the values that are essential for health and healthcare within our community. These individuals are members of our community. With great wealth comes great responsibility. I don't think that was Spider-Man, it was John F. Kennedy, actually, but but nevertheless, having said that, we have this opportunity. We have this responsibility. And so I'd hope to engage all of you in that discussion about how we could do it in your context. And this is just a whole bunch of different pictures. We have weddings and funerals, and we have Christmas parties. They come to I live on a farm. All the homeless guys come up. They've already told me when they're coming up to the farm. They're going to cut a Christmas tree at my farm. Homeless alcoholics, chainsaws, you might think is not such a good idea. But nevertheless, they've already defined who's going to be doing the chainsawing. but we've had artists, a rich number of fantastic people, which I suspect each and every one of you would think you have your own examples of people who have wonderful expertise in history. Tragic, but equally wonderful. So I count myself very fortunate to be part of that community. So I'll stop at that. And then I think we're going to ask questions now, aren't we? Yeah?